Hi, everyone. Welcome to our Spotlight series. Today, we're going to be talking to Dr. Aditi Menon, who is a pain management physician who specializes in sports medicine, regenerative medicine, and just overall holistic health. Dr. Menon focuses on helping patients to get out of pain, to get back to what they're doing and what they love doing. She's very focused on function and helping people to try to avoid surgery as much as possible, avoid being on medications long term, and she's very, very forward thinking in terms of how she approaches patient care. So, welcome to our Spotlight series today. We're so happy to have you here.
Thank you. It's wonderful to be here.
We'll be talking about your approach to pain management, a bit about your practice, regenerative medicine in general, if there's anything you want to add that I don't ask, then make sure that you definitely add that so that we can help the people who are listening to this. So firstly, just give us a little bit of a background and share your journey, how you got into pain management and what made you specialize in that area of medicine and regenerative medicine specifically.
Absolutely. I actually did all my medical school training in New York. I'm did my medical school at SUNY Brooklyn Downstate, which is a wonderful place just to get a lot of exposure to pretty much everything. So very hands-on. And then I did my residency training at New York Presbyterian at Columbia and Cornell. And we did a lot of training at Hospital for Special Surgery, Memorial Sloan Kettering, in addition to Columbia Presbyterian and Weill Cornell. The good thing about that, we get exposed to a lot of not only functional medicine and, of course, the neurological aspects such as, strokes and spinal cord injury. We do get a lot of exposure to musculoskeletal medicine, orthopedics. And I was fortunate enough at that time regenerative medicine such as platelet-rich plasma and stem cells were coming up. So seeing a lot of research specifically at Weill Cornell and Hospital for Special Surgery really piqued my interest even during that time. So that's a lot of research was being done in the musculoskeletal and orthopedic realm of regenerative medicine. So that's when especially HSS was doing a lot of those things. So, learning about it there, and really the whole goal was kind of taking what they do and the way they do it and really doing that now in my practice currently. So even a lot of the things that I use, be it platelet-rich plasma kits or the BMAC, which is the bone marrow or adipose tissue, it's the same exact ones that Hospital for Special Surgery uses. So which is good because that clinical trials have been done on them. They've been tried and tested. And these are people who are very heavily research based. So
Yeah.
I like the fact that it's not just coming out of nowhere. It's, research based clinical data has shown that this has worked. So we're really doing the same exact, equipment that's used there in my practice currently. So that's how
Very
I kind
cool.
of got into it. And then I realized there's just so many patients that I see that have that, be it an older patient who has osteoarthritis and pain from that, or an athlete who's professional and they're training and they get overuse injury or tears, or even your regular the weekend warrior where they're constantly working every day. So the posture, their commute, everything. So how can we improve the function, decrease the pain without a surgical approach?
And would you say that most patients come to you with the goal of avoiding surgery?
Yeah, definitely. I think the main thing, yes, I do have that occasional, someone's like, okay, you know what, I know I need surgery. I'm trying to avoid it. I want to do this, before, I do surgery. I want to try this one last time. But majority of the patients is like, I really don't want to do surgery.
Right.
What
Yeah.
can we do to avoid that? And really not just mask it.
So I know when I came to your practice to visit you, I felt like you were very unique in how you approached regenerative medicine and just, like I think part of it is that you use the same equipment that's at HSS and maybe even similar protocols. Um, So tell us a little bit about what makes your practice unique.
So one thing is really figuring out that diagnostic portion. So when somebody first comes to me, of course, the main thing is to figure out where is this all stemming from? Because as a lot of times the symptoms can be textbook cases, but many times it's a mixed, where, for example, a lot of times the neck and the shoulder pain mimic each other. Same thing as like back and hip. So to really try to get the proper diagnosis, so I do a full evaluation, not only listen to their history and their goals of what they want to do, because that's very important, but really a full exam. If I need to send them out for any diagnostics such as MRIs or x-rays, I also do in the office something called EMG or nerve conduction studies. So if there's any numbness, tingling, or any type of musculoskeletal issue that might involve nerve, a lot of times diagnostics with that also helps. I do a lot of ultrasound guidance in my office, but at the same time, if I feel like, what, let me take a look at this area with ultrasound while I'm evaluating you. So I try to put that into the mix as well. So it's not just an evaluation if ultrasound is needed to just further improve that evaluation. So really, number one is making sure where me and the patient is on the same page of what's happening, and then coming up with a treatment plan together. I never like to look at someone as this is a knee, this is a back, this is a neck. No, it's like the whole body. So I really want to make sure we're looking at the person as a whole, and because it's all connected, like it or not, that one thing affects the other. So really
Yep.
not just treating one body part, but just really treating the whole body, physically, but of course every component of it, and then really discussing what are the different treatment plans that we can do to help, not number one, to get to where this is coming from and how to improve that. So I
So
think that
let's
is that
say
approach.
if we referred a patient to you or any patient made an
Mhm.
appointment with you, what are the initial steps? Like they call the office and they say, I'm having pain, but they're
Sure.
not necessarily making an appointment for a specific type of treatment because you're going to recommend that after the consultation. So can you just walk us through what the steps would be so that, patient that potentially might be considering this has a better understanding of like what the process looks like?
Sure. So first they'll call the office and they'll say, "Hey, I'm experiencing." Most people, really don't know what treatment they're looking for. A lot of it is really, I have this pain. What can I do about it? I need this taken care of. So really, what is their pain? And then we will verify their insurance. So if you have insurance, we verify it and we'll let you know, how the whole thing works, and then we'll make an appointment. When you come in for the appointment, there is an intake form that tells, not only, your past medical history, but also where your pain is, what makes it better, worse, any diagnostics you've had. So doing that whole intake is important. And then, seeing me, and then doing a full evaluation. So that first initial eval is very important. And I like to spend a lot of time.
How
I know
long is that
mo
appointment?
So usually it's about an hour.
Oh,
I know most pain doctors, they'll spend 10, 15 minutes.
yeah,
I,
so that's
I'm
like very unique. I feel like that makes
Yes,
your practice
yes.
very special to spend an hour with someone.
Yeah, I feel like that initial visit is so important. Do I have
Hmm.
some people who are simple and it's done in 45 minutes? Sure, but usually, I like to look at the whole thing. So you're
Hmm.
there for about an hour the first time, because I really, really want to make sure we are looking and assessing the whole issue and
Hmm.
every aspect of it.
Correct.
So I don't want it to be, and that's really one of the reasons I used to be part of a group practice that I ventured on my own, was to really be able to spend that time with my patients. And soon, everybody knows they're kind of like, they become like family members, so
Mhm.
it's like, how would you want to be treated if this was your mother or if this was your relative? So you really want to give that undivided attention.
That's
So
amazing.
yeah, so I always do that the first the first evaluation is so important. So that, and then at the end of it, really, once we do the whole thing, I explain the whole process to you, not just, what your pain is, but if you have imaging, going through those images together, really explaining exactly what's happening to the body, because I feel like education is number one.
Mhm.
So if you can understand what's happening to you, you're better equipped as well,
Yeah.
So I never want anyone thinking that, okay, you know what, I'm just giving you information, you're taking it. No, it's a interaction together,
Hmm.
you know.
Yeah.
So, and education is a big part of it. And even any treatment plans I suggest, it would be something we come up together. And I might not necessarily always do number one regenerative, say, someone's like, no, I really want to make sure first we do whatever is covered through insurance first. But even with that, there's so many things we can do that are holistic, where I'm not giving you just pain medications and a cortisone injection. Um, there's, other things we can do that will actually help treat it. And it's, the insurance covers it as well.
So what are some of those things that you might,
Do
do
that.
first?
I think one of the main things is something called a trigger point injection. I know that most people think of that as just an injection with cortisone, and a lot of physicians do it that way. They'll just inject an area and they just put a little cortisone. Trigger points are really when you're trying to go and break up that tightness or spasm in that area,
Mhm.
be it in, neck, mid back, low back, but it could be your pelvic area. It could be, extremity area where, because of the pathology, there is myofascial bands that have formed.
Mhm.
Basically, that's a fancy term for spasms or knots in that area. And breaking it up is very important. I know one of the main areas is your trapezius.
Yeah.
That everybody's like my neck, and
Mhm.
the traps area is like a big rock. So it's
Correct.
how do we break that apart? So I go in there with a very, very thin, almost like an acupuncture needle, and I do
Mhm.
something called a hydrodissection, which what it is you're putting saline and lidocaine, and
Mhm.
you break it up and you're flushing that area out. So when you do that, you're actually detoxing it. So put t- going in there and breaking it up and kind of putting the saline and lidocaine, flushes it out. It breaks up the tightness, but it's also bringing blood flow to that area to break it
Okay.
up. It's almost like a prolotherapy. In prolotherapy, you're using sugar water or dextrose to
Mhm.
cause irritant to the local area.
Okay.
So it's very similar, but with lidocaine and saline. So I grow and break it up, and putting that gets that blood flow to that area and starts repairing the region.
Okay, so then that's interesting because you said most doctors, and I have experienced this, most doctors do use cortisone or
Mhm.
other things. Sometimes they'll use lidocaine too.
Yeah, usually when they use cortisone, they'll use cortisone and lidocaine together.
Mhm.
But if I can try to avoid the cortisone, I would prefer that. Do I have some people who come in and they're like, I cannot move my shoulder at all? Like it's just,
Mhm.
or I have, severe tendonitis and I have to decrease that inflammation. So there is a time and place for cortisone. So it's not that you never want to use it,
Yeah.
but you want to use it only when required,
Hmm.
and it's going to help. And doing it in small quantities and doses can help. It's when you're overusing it that it can really be detrimental,
Right.
because it can worsen arthritis. It can, certain areas, like if you put in your Achilles, it can have a risk of tears or
Right.
rupture. So you want to be very careful of how you're doing it, but there is a time and place for it if
Hmm.
done properly.
So you can do hydrodissections in the muscle, but also I've had patients who've had it done for frozen shoulder. So is that within the joint
Absolutely.
capsule?
So the frozen shoulder is one of the best areas to do hydrodissection.
Hmm.
And more patients I'm seeing with perimenopause, especially now,
Yes.
as we are active, women, but at the same time, the hormonal changes is causing a lot of areas of pain and stiffness. Shoulders are notorious for that.
Hmm.
So going in and hydrodissecting that area, flushing that area with saline and lidocaine really helps loosen that capsule.
Mm-hmm.
and then doing physical therapy afterwards
That's
to
what I was
help
going to ask at
mobilize
what
it.
point in the PT. So, like, if we get a patient who comes
Yes.
for frozen shoulder, doing the hydrodissection in the beginning, followed by the physical therapy, would be the best route.
Absolutely,
Okay.
absolutely. So for me, physical therapy is so important. It goes hand in hand with what I do.
Hmm.
So if I'm, causing that area to be more loose, more flexible, um, decreased in pain and inflammation, guess what? You can't just do that and not do anything else.
Right. You
It
have
has
to
to be
reinforce.
strengthened. There has to be stabilization of that area. So that's where PT comes hand in hand.
Hmm.
So someone doing that hydrodissection of the shoulder and that capsule and then doing physical therapy right after is so important. They
Awesome.
have to be done together. Otherwise, you're just missing out on a
Yeah.
lot of
I've
um,
actually just in the past few years seen more success with hydrodissections for frozen shoulder than cortisone shots.
absolutely. It is true. Because the cortisone, if they're in a lot of pain, yes, I
Pain.
might put a little cortisone to calm it down. But with that, I will also do the hydrodissection because I
And could
feel
you do
like
that in one session, in
we
one?
can
Okay.
absolutely, it
Okay.
could be all under one procedure. And I
Okay.
do them ultrasound guided.
Mm-hmm.
So most of my, joint or injections are done under ultrasound guidance. It's really good because you're going precisely to where I need to go.
Mm-hmm.
So that gives you definitely an improved outcome than
Yeah.
doing it blindly, for
Yeah.
sure. That helps. And even for frozen shoulder, I've seen Riedel do a hydrous dissection, loosen it up, and then, if I say I do an MRI and I also find a partial tear in addition to it or a labrum tear, then we'll follow it up with PRP, platelet rich plasma, which will help heal those tears too. And
Okay.
it actually helps with the capsule.
Mm-hmm.
Initially, there's inflammation, but it does help with it. So that
Yeah.
combination really helps. And there's been actually research articles on that for frozen
Okay.
shoulder.
So just since we're on the topic of frozen shoulder, which is very common,
Mhm.
just want to talk a little bit about plantar fasciitis. Seems to be
Yeah,
very common too.
absolutely.
What would be your first line of defense for that?
So plantar fasciitis, people, you have to be careful with cortisone. If sometimes I do cortisone for it, you have to be a little careful because you don't want to put cortisone into the fat pad. If
Mm-hmm.
that happens, your fat pad will atrophy,
And the
and that
fat pad,
will
just for people listening who might not know what that is,
oh,
that's like the bottom of the heel. Right. Okay.
exactly. There's cushioning in the bottom of the heel, and that cushioning is basically fat. So
Mm-hmm.
if I'm putting cortisone into the fat, and that can actually cause the fat to thin out. So if you have thinning of cushioning underneath your foot, that can lead to worsening of your arthritis and your tendinosis. So when you do cortisone, you want to make sure you're going to the calcaneal bone area and calming down that, again, ultrasound guided, calming down that inflammation. But even hydrodissection and, believe it or not, PRP works amazing to
Okay.
it. I actually had someone recently who had plantar fasciitis and a Morton's neuroma, which is Morton's neuroma comes usually between your toes. You
Mm-hmm.
feel like a pebble or tingling and it's not going away. I actually did hydrodissection a few times. We did it um, about twice and it helped so much, much more than cortisone.
Yeah.
You know, it
That's
was
really interesting.
incredible how well they did with it.
Right.
Yeah, and even the plantar fascia, of course, we want to follow it up with proper PT,
Mhm.
but really breaking it up without causing any side effects, because
Yeah.
you want to keep that area um, number one protected and stabilize it. So you don't want anything to destroy that
Yeah. That's a
region.
really, really common
Hmm.
thing that we see a lot. So in terms of like who your ideal client would be, like obviously someone who's trying to avoid surgery, but like who would be a good candidate to come and see you?
So I see all types of patients. I do, from I don't see as many very, very young children. I have seen them though. I would say um, active adults. They can be anywhere. from their 20s all the way to really their 80s, or I've seen even older than that, but really active adults who are want to continue their lifestyle, want to stay active, and really are trying to avoid, of course, surgery, but then avoid anything that might, cause them to be sedentary, so we really want to help them to stay active, to be functional and do what they like. Yes, do I see professional athletes? I do. But I also see people who are like, you know what? I'm not a professional athlete, but I love going to the gym, or I
Yeah.
love my runs. I like doing my Pilates or my triathlons. My, they're very active. Or I have
Yeah.
some older patients who are like, I love gardening
Mm-hmm.
and, I want to keep this up, or I like going for my evening walks and I'm not able to do it anymore.
Hmm.
So, those are the people that really, come to me and help. And of course, I do get high school athletes as well.
Yeah.
So,
So most people they've probably already tried maybe physical therapy, chiropractic, acupuncture, other types of treatments that haven't helped, and now they're looking for their next step.
mhm,
Usually by the
yes,
time they see you, or are you usually the first person they
I
might?
have a I have both.
Okay.
So I have some people who have actually done everything. They've even like I have some people who've even done surgeries, or they've
Mhm.
done treatments, they've done PT, everything, and they're coming almost like a second opinion, third opinion, to
Yeah.
see, okay, what can I do now? I'm kind
Mhm.
of this not improving. And then I also see people who've really, I have pain, I've ignored it, not done anything about it.
Yeah.
And what's my next step? What do I do? They haven't done physical therapy. Some people are afraid to do any treatment. They just feel like it's going to go away.
Hmm.
And only if it's once it gets really bad, then they see someone.
Yeah.
And I would definitely encourage that. Don't, I mean, of course, if that's you, come at any point, but don't wait,
Yeah.
don't wait for it to go that bad. Like when you start feeling something that is hindering any of your function,
Hmm.
you should be like, okay, let's get this checked out,
Yeah.
properly.
And the
So,
longer you wait, the harder it is to reverse things. I mean, it just might take multiple treatments versus like one or two. Like, what is the typical number of treatments that, like let's say, I guess someone's been in pain for 6 to 8 months and they're finally getting around to coming to you.
right.
What is the typical number of sessions you might need to see them for, or treatments they might need? Like three?
So it all depends on which treatment they do. Say they're
Mhm.
doing like, say something like trigger points, right?
Mhm.
Where they're doing that hydrodissection. So then yes, we might need 3 or 4 sessions of it to really calm it
Okay.
down. And but then if there is somebody who has a tear, like say, and the reason here I'm saying not waiting, because it might have started off with like a very small tear, and then
Mhm.
you're like pushing through it, and then that can get larger. You don't want it to become a full thickness, complete tear before
Correct.
you come, because that is very difficult to treat without surgery when it becomes a complete tear.
So,
But
like
say,
for example, for like a rotator cuff tear,
mhm. So
it would have to be 75% or less, or 50% or less
so
for them.
so rotator cuff tear, I would say about, you know a small to moderate partial tear. It
Mm-hmm.
has to be, I had patients who have almost complete tears and they're like, I'm not doing surgery regardless. Then I definitely had that too.
Okay.
So, but then so if someone comes to me, say they have a rotator cuff tear, we
Mm-hmm.
do an evaluation, um, functional loss, MRI shows that the rotator cuff tear is there. If it's a small partial tear, usually what I recommend is platelet-rich plasma. And for those who don't know, platelet-rich plasma comes from your own blood. So we draw the blood, I centrifuge it. So, and we separate the red blood cells from the plasma. And
Mm-hmm.
then the plasma is taken and then we centrifuge it again. So this is a double spin kit. And if you do your research, double spin kits always yield more platelets and growth factors.
Okay.
So once we spin it again, it's very concentrated. So now you can get up to 14 times concentration of platelets, which
Mm-hmm.
has proteins and growth factors that help with healing. So I always tell like someone, if you get a cut, so when you have a cut in your hand, what happens, the body brings growth factors, platelets to the area to heal the cut. So now we're taking these proteins and growth factors, concentrating it, and with guidance of where the tear is, we put it right into the tear.
Mm.
So when you're putting these growth factors right into that area of tear, it starts healing it. It is inflammatory because remember, these growth factors are inflammatory. So
Mm-hmm.
I always say don't take any anti-inflammatories because that will take away the effect. But
Correct.
this is such a concentrated platelet-rich plasma that many times just one is enough.
Mm-hmm.
But it also depends on how your body heals. So
Eels.
I've noticed that the younger athlete in their 20s tend to heal very, very well
Yeah.
because of, they're getting a lot more blood flow to the area, where an older person who has, their platelets might not be as potent, they take a little bit time. And also degeneration has happened at that time.
Right.
But many times one is enough.
Mm-hmm.
Sometimes I may repeat it depending on how you do. It takes about 6 to 8 weeks to see the results because that's how long it takes for any healing of tissue to occur.
Yeah.
Even with a cut, even post surgery, if you see that magic number is 6 to 8 weeks.
68. Mm-hmm.
Yeah. So once I see 6 to 8 weeks, that's when I say, okay, do we need to do another one? Or do
Okay.
we kind of see how this goes?
Okay.
Um, but if it becomes a more serious issue, say that it's now a, more than like a small partial tear, there
Mm-hmm.
is a larger tear or multiple tears. You have a labrum tear as well as a rotator cuff and arthritis. Say there's multiple things happening.
Mm-hmm.
Then the other thing I suggest is something called stem cell therapy.
Okay.
So stem cell therapy is even more potent because not only it has the growth factors, it has mesenchymal stem cells. Now, stem cells are what we have in our bodies when it's a cell that turns into other cells. So
Okay.
if you have, um, cartilage, you're trying to, when you put stem cells in there, you're trying to repair the cartilage by, of course, growth factor repairing, blood flow coming into the area, but actually the stem cells becoming that cartilage cell. Or that, when you have the tear of the rotator cuff, it's actually replacing that tissue. So you're getting, real, um, not only improvement, but regeneration of that tissue. So truly a
Amazing.
regenerative.
Yeah.
And the best so far, bone marrow is the most studied. So there's bone marrow that's from your own body. So
Mm-hmm.
it's not as bad as you think. A lot of people get a little scared, like, oh goodness, you're going to take out bone marrow from me. We take it out from the hip, right by the pelvic bone, the iliac crest.
Mm-hmm.
And it is not bad at all. I mean, we lidocaine it, and the whole thing is done in front of you. So um, lidocaine actually, most people, they say 0 to 10, how painful is that procedure. They'll say 1 to 2, truthfully.
Okay.
They'll say
That's
it's
good
more
to
of
know.
a discomfort. It's not terrible.
Okay.
So because we put a lot of local anesthesia, so
Mm-hmm.
everyone is pretty comfortable.
Okay,
And
good.
so we take the bone marrow, it's centrifuge, we filter it, and then the stem cells it has a red blood cell component too. So you have that almost like a PRP plus stem cell component, and it goes right back in, be it for knee arthritis. I have some people who are pretty moderate to severe knee arthritis. It works wonderful for that. But
Okay.
even for shoulder OA or tears, really, the bone marrow is wonderful. Those who, some people, adipose tissue also works, which is your fat. Not many people know fat is filled with stem cells. It works great, but it is a little thicker, so it works better in joints like your knees or your hips, but and your shoulders, but you can't really put it in soft tendon areas. That's where the bone marrow is a little better because it's just
So
thicker.
for example, if you're doing like an Achilles
Yes.
tendinopathy or like a tennis elbow, golfer's
Elbow,
elbow, you would
exactly.
probably choose stem cell or PRP versus if it was knee OA, you would probably choose
So they're both stem cells. So adipose
oh,
tissue and bone marrow are both stem
oh
cells.
stem. Sorry.
But
So
I would
like
choose the bone marrow or the
gotcha.
PRP
For the
um,
tendon.
instead of the adipose tissue.
I see.
Absolutely. So I would do a bone marrow stem cell or the platelet-rich plasma instead of the adipose tissue stem cell.
Okay.
There's a third type of stem cell called, it's not from you, it's called umbilical cord stem cell.
All right.
So these are from the Wharton's jelly of the umbilical cord. These are all live births, they're donated. People do really, really well with that because it's very potent.
Mm-hmm.
You're having very, very potent stem cells. Those are a little, you have to be careful because I always, thank goodness there's been some very good companies where I'm getting amazing results from. But you have to be careful because there's a lot of places, there's so many out there, like what is being used.
Oh wow.
You have to make sure that it's coming from the right source and it is done properly, but it has tremendous potential. And I recently had someone who had pretty significant knee arthritis,
Mm-hmm.
and she was older, didn't want to do the bone marrow or anything invasive. So we
Okay.
did the umbilical cord stem cell for her knee arthritis. She's doing wonderfully, like
That's
really,
amazing.
really well. Of course, it took about same thing, 6 to 8 weeks to start seeing the results.
Mm-hmm.
Her really got better after, I would say, 3 months. It took a little longer, but now she's back. She loves gardening, so she's back to her
Yeah,
gardening. Of course, we monitor, make sure it's okay. Um, and she did the therapy. Did all the right steps,
correct.
and the results were very, very good. And
Now, would this person have to come back for like a touch up or anything at a later point?
sometimes they do, depending. So I have like one other person 3 years ago. She did bone marrow for both her knees. She's
Mm-hmm.
she's 85. Did really well. And what she does yearly, she does a PRP
Okay.
just to maintain it.
Okay.
She's noticed, and we've both noticed that doing the PRP, along with there's something called hyaluronic acid gel injections for the
Mm-hmm.
knee, which
Mm-hmm.
helps lubricate the knee, and that's covered through your insurance. So doing the two together has helped maintain it.
Wow.
So that really helps. So despite her have done the stem cell, she still does a yearly maintenance of those two.
Okay. That's
And
awesome.
but
But she's
she's
been
now,
able to avoid
yeah, she's
total knee
87
replacement.
now,
That's
and she's
amazing.
avoided the knee replacement. She's like, I'm not doing a knee replacement. She's doing great. And she was definitely one of those candidates of knee replacement.
Wow.
Um, and I'm not saying that everybody who has severe arthritis, you know, will be a candidate for this. They very well might need one knee replacement. So, um, there was one person who had severe hip OA, and despite stem cell, still needed a hip replacement.
Mm,
So it's really I always have a very, very honest talk about, okay, where in the stage are you that, are will you might need surgery eventually anyway, versus this is no, you have a very good chance without surgery.
okay.
Yeah,
Yeah, no, that's really, really, I mean, these stories that you told about how your patients got better, I can already think of like three patients to send you.
yeah, no, eh,
Because they definitely are like, I don't ever want to have surgery. Like,
right.
people definitely want to avoid that. So that's really, really helpful.
And then there's a time and place for everything, and I have personally said that, okay, let's try this, and then if we need to have a surgical approach, we will. But many people have been able to avoid it. So there's been someone who had a pretty severe rotator cuff, and I was like, okay, and I was very honest that I'm not sure, with this almost being it wasn't a full tear yet, but it was almost there.
Hmm.
But he was an athlete. He's like, no, I really can't have, and shoulder is a tough surgery, like the rehab after. He's like, I need to be recruited. I don't have time to do any surgery. He did bone marrow for it because it was really severe. I normally say PRP, but he did bone marrow and results were amazing. Like
Wow.
never needed surgery. And we were both surprised because the way his tear looked, I was kind of like, okay, he might be a surgical candidate, but he wasn't. He did great. So things
Okay.
surprise you, you know?
Yeah,
And
you never know how the body's going to heal, you know?
exactly, exactly.
Right.
But the key is we're in it together.
Hmm.
Like it's really like we are working together, and not just I'm the physician and you're just going to listen to what I say. No way. It's always we're working at this as a team to
Hmm.
get them better together,
Yeah.
you
So
know.
just to kind of summarize everything we talked about, someone who is considering coming to see you, they may or may not have tried other treatments, but like even then, like there's so many different options, whether it's the hydrodissections, the PRP, the stem cell, the bone marrow, like so many different options to help people to avoid surgery, avoid being on pain medications long term. Like I know that we have patients who are on pain medications who want to get off pain medications.
Yes.
We've referred them to you for that, but with the goal of, being able to continue to stay active. The best way to get in touch with you, if people do want to come and see you, is to call your office, or do they go online? Do you have a
Oh,
website?
sure. So both, I have, they can call the office or they can email or go through the website and through that they can book as well. So my website, and I'm sure you'll put it in there too. It's so the name of my practice is Menon Regenerative Institute. Menon as for my last name. So the website is MenonRegen.com. And the office number is 973-382-5002. So they can, call as well. And then if you go to the website, there's also email. If you prefer to email, you can email directly there. It's admin@menonregen.com, for any questions. And anytime you want to even just call for a consult, say, you know what, I'm not sure if I'm a candidate or if I want to, I'm just not sure. We can just do a consult and see, where you are and what are the things we can offer and if this will be a good fit for you. And not necessarily if you come to me, you have to do regenerative medicine. Like I said, there's so many people who come to me just for a PT script
Right.
or just to get a diagnostic
Get
of.
a second opinion or what else is going on.
Absolutely, absolutely. Like,
That's really
what's
important.
happening. Yeah. So not necessarily that we have to do, or it could be, hey, I want to come to you, but I only want to do what's covered. And
Mhm.
absolutely, like I said, we work together. So
So
it's
there's so
never.
many different options, and yep.
Yes. And when it comes to the holistic realm, I also do a lot of vitamin infusions. So I've noticed that sometimes with the hydrodissection, I'll add a little B12
Okay.
to just do like a natural anti-inflammatory, or if I see someone's very like low in energy and things like that, we might do a B12 glutathione or an infusion with, I have one person who's autoimmune and she does infusions with like glutathione, taurine, which are amino acids, but magnesium, all the B's,
All good
um,
stuff.
all the good stuff. And then they also do something called NAD,
Hmm.
um, which helps with just overall wellness and some
Yeah.
peptides. So everybody is catered differently. And according to the approach they want to do, I will try to kind of customize that for them.
Do you, just as a last question, and just because you brought it up, like I know a lot of patients will seek out functional medicine doctors to kind of get like a full panel done of like their vitamin D and B12 and magnesium, all of the things. So do you ever do those panels too? Or do you ever see there's a need for that?
So I do panels as well. And then the funny thing is I even have like some functional medicine doctors I work with too,
Mhm.
that they might do a panel and they'll like, we'll work together
Yeah.
with that. So yes, there are certain times where I do the panels. I do would say that functional medicine doctors sometimes they'll do extra ones than your regular.
Okay.
So I'll work hand in hand with them, or even a rheumatologist. I might start up if I think there is some systemic autoimmune ha you know, disease happening, I might start off with, the panels and things,
Yeah.
and then refer to a
Sure.
rheumatologist for
Hmm.
further, and then the rheumatologist it sometimes sends them back to me, and we go back and forth like, hey, this person really doesn't want to do a traditional methotrexate harsh medications. Let's do a more vitamin-based, peptide-based treatment for
Hmm.
them, and that's what we do.
Very cool. I mean, I
Yeah.
love that you have a very like holistic and natural way of treating patients. And that's what people are looking for now.
Yeah.
Everyone's
Yeah.
trying to be as natural as possible. So I think it's amazing. Um,
No, I-
so I'll make sure to include all of your contact information so people can get in touch
absolutely.
with you. And this was really, really valuable information. I think it was really helpful for me and also for our listeners. So I think it'll be hopefully you'll be getting some calls and referrals
Thank
from this.
no,
So
thank
thank
you so
you so much
much.
for being here, and I will send you over the recording.
Thank you so much, and you've been amazing. And even all the patients I've spoken to, they absolutely love the treatment they get with you.
That's good. That's
Yeah,
good.
it's always good to work together to
Yeah,
really help someone, and I
yeah,
think that's the
100.
reason why we do this.
Yeah, that's so
Yeah,
true.
yeah.
Thank you so much.
Thank you, my dear. Thank you.